start, sir.
Correct. Absolutely right. Broad spectrum antibiotics really play a very important role. Then we have Aniket. Aniket, good evening. Tell me, what is your experience?
We had one pregnant female patient who had a road traffic accident, and she delivered in the rickshaw only. So she was operated outside in GMC Nagpur. So she was done, tibia nailing was done bilateral. And then she came to us after postpartum. She had pleural sepsis, and she had necrotizing fasciitis in both the lower limbs. We had to amputate the limb. We couldn't save it. We tried a lot with plastic surgeon also. We tried flap, but it failed. So we had to do bilateral amputation.
Bad, sad story.
So
last comment.
Difficult to treat.
Yes, absolutely. Last input by Surya Prakash, and then we will start. Surya Prakash, you there? Surya Prakash? It's possibly muted. Okay. I think it's already 9:15, sorry, 7:15. So let's start. So good evening, friends. I welcome you to the 6th module on soft tissue infections. So we would essentially cover necrotizing fasciitis, imaging in soft tissue infections. Then we are often confused about whether it is cellulitis or necrotizing or developing abscess. So we will briefly discuss that. Pyomyositis is a very, very challenging situation. So we will have a few cases. Then I'm sure you must have come across infections after tendon injury, especially post tendo Achilles repair. And we will discuss a few things about that. If time permits, we will discuss about soft tissue infections when the bed is poor. And lastly, of course, we will analyze what all we discussed today. So necrotizing fasciitis is actually, it means flesh-eating bacteria. And to be very honest, this is one condition where I'm often unhappy after my debridement. And I'm extremely concerned about morbidity and mortality. Exactly like Aniket said, that they had a patient with bilateral necrotizing fasciitis and they had to amputate both sides. So what is necrotizing fasciitis? It's an inflammatory infection in the deep fascia. It is in deep fascia, but causes secondarily necrosis of subcutaneous tissue. So the infection spreads along the deep fascia and continues to progress, and very often life-threatening or limb-threatening. Now, the extent of fascial involvement is generally more than what is obvious superficially. So inside, deep inside, you will have extensive involvement, but superficially, you will have very minimal changes. It is classified into different varieties. Why I am discussing this is these varieties represent the causative factors. Type 1 is polymicrobial and generally associated with diabetes. Type 2, you see one streptococcal necrotizing fasciitis, you will never forget his life. Generally after mild trauma. Seawater infections are becoming more common. Just a scratch and you enter seawater, you are likely to get infected with gram-negative bacteria or Vibrio or Ehrlichiosis. These funny things are known. And last but not the least are the incidence of immunocompromised patients are increasing, and they are likely to get infected with Clostridia. Generally, it follows a small injury. It could be just paper cut, could be pinprick, nail injury, it could be insect bite. So through all these, with weakened skin, the bacteria can enter and then cause infection of deep fascia. So many factors are associated with this: old age, any severe illness, diabetes, obesity, alcohol, and immunosuppression. Most of the patients have one of these. Now, they spread from subcutaneous tissue along superficial and deep facial planes. Now, this deep facial plane can cause vascular occlusion. See, whatever is going through the deep fascia, whether it is vessels or nerves, are likely to get involved. If vessels get involved, then it will cause vascular occlusion and necrosis. The nerves may get involved and can cause localized anesthesia in the area of the nerve dermatome. But locally, generally, there is very severe pain. You may have a small pinprick or small abrasion, but the patient may complain of excruciating pain, and that is what should point to this diagnosis of necrotizing fasciitis. Obviously, any inflammation, there is redness and warmth, and there would be these patches at various places. Over a period of time, they generally have fever, dizziness, extreme weakness. They can have diarrhea and nausea. And one finding is intense thirst because they often get dehydrated. As time passes, you can see such skin affection is well known. It's a large area of skin necrosis and these multiple patches or rash along going proximally. The skin may get discolored or peeled. By about 5th day, if they are totally untreated, then they can have hypotension, toxic shock, and anything can happen. How do we investigate? Various investigations, but there is something called LRINEC score, and it analyzes CRP. If it is more than 150, then the score is 4. WBC count less than 15,000 is generally not likely to be necrotizing, but between 15,000 to 25,000, give 1 score. More than 25 is 2 score. Same with hemoglobin or sodium, creatinine, and glucose. So all these things are graded and scored. If the score is less than 6, necrotizing fasciitis is unlikely. If it is more than 8, it is highly predictive of necrotizing fasciitis. And as Lester said, that broad spectrum antibiotics to be initiated ASAP, mostly ampicillin, sulbactam, or piperacin, tazobactam, and metronidazole and clindamycin. Here, we don't wait for antibiotic-free interval. Remember, don't think that Dr. Agash and Dr. Menon insisted on antibiotic-free interval. In this case, we have to start antibiotics ASAP, and emergency surgical debridement of affected tissue is the most important. Remember, the affected tissue is much more inside than what you see outside. So once you have excised, then go up to healthy tissues. One may need multiple debridements, but what is important is obtaining tissue like this and then optimize the wound using negative pressure therapy and close. These would be the steps of management. So I'll discuss a few cases. This middle-aged person came at 5 days. You can see dorsally, there is a total necrosis of the skin with pus underneath. On the medial side, you can see small blisters, but there is very funny kind of appearance of the skin. He had fever, He had varicose vein surgery a few years ago and not very compliant in wearing stockings. His WBC count is high, 20,000. CRP is very high. USG showed collection in facial planes. Now, Dr. Menon is going to discuss about these imaging, so I'll not elaborate on this. Whatever it is, scores, etc., are important, but in this case, the diagnosis is obvious. This is necrotizing, and one has to address it as early as possible. So you can see what happens. This is the deep fascia. The infection is along the deep facial plane, which is totally necrotic. On the medial side also, you can see there is collection. We aspirated pus, and this shows the pathology very well. That's the deep fascia which is infected and the subcutaneous tissue which is necrotic. So the biggest challenge in these cases is how much to debride. Day one, often one is conservative, and that is the drawback of, not drawback, I would say, that is the downside of necrotizing fasciitis. They don't debride adequately, they don't settle. Now here you can see the edge still appears necrotic. I'm not happy, but somehow I stopped because the patient was very uncomfortable. I really didn't know whether I am doing an appropriate job by doing a good debridement, so I applied VAC. Here you can see second debridement. Again, there are some areas of necrotic deep fascia. The problem is, while excising the necrotic fascia, the tendon sheath often gets excised and the tendon gets exposed, and one is scared that the tendon may lose its blood supply and die. So this is what happens. Intraoperatively, he had polymicrobial infection, E. coli, Aeromonas, Pseudomonas, and he was started on ciprofloxacin. Now here you can see, on fourth debridement, I am generally happy. But something like this should be done on day one. So what I'm trying to show is the mindset of an average orthopedic surgeon. This is exactly what I went through. This is the fourth time I had debribed it, but I should have achieved this on day one or max day two. So finally, this is where I am extreme left side corner, and then we could do a split thickness graft, and graft was taken quite well. This is last debridement. So if it is dead, it is dead. You need to have only alive tissues. Expose the muscles, no problem. This is him at 18 months. He came back with a non-healing ulcer, essentially because of his varicosities. So this case gave me a good lesson. So when this second patient came in, 70-year-old diabetic, left leg swelling 3 days, and came in shock, hypotension, hypoglycemia, drowsy. As soon as he came in, casualty, he was started on NORAD drip and vasopressin because the BP was really low. He had to be amputated. So this is how he has come. You can see significant swelling of the lower limb. His WBC is very high, sodium is borderline low. His creat is 4.9 from apparently normal creat a few days ago. So obviously he has infection in left lower leg. Is it abscess? Is it necrotizing? It's difficult to say. But with a working diagnosis, because there were patches, working diagnosis of necrotizing fasciitis, but generally you don't have that kind of swelling, so much swelling of calf in necrotizing. So I thought he possibly has developed a compartment syndrome also. There was no time to find out what it was. We took death on table consent and we opened the skin and compartment. So this is the kind of excision of the skin I did. This is the kind of release I did. And post-VAC, we could do just second sitting, we could do a split thickness graft. This is the lateral compartment which was closed. The medial skin could not be closed. And you can see within no time, his WBC count has decreased. Creat from 4.9 has come down to 0.8. He was conscious, oriented, extubated, off any support. So within no time, he settled. This is at 7 months, and this is follow-up at 18 months. Very, very comfortable patient. And here you can see the parameters. When we explored, he was around 29,000 and came down by about 2 weeks. Counts have come down to 7,800. Platelets have increased. Creat from 4.9 has come down to 0.8. And inotrope supports were totally off. This case, the first case as I showed, as I discussed, told me that unless you are very aggressive, you don't win over necrotizing fasciitis. So when this patient came in with a dog bite, here he is. 2 years ago, he had a dog bite and it had never healed. After that, he went to Phuket and entered seawater and developed another discharging sinus, significant pain. The area started becoming necrotic, so he was treated elsewhere. Swab was taken, which showed erymonos, and he was treated appropriately. So this is the kind of debridement you should do. Here you can see the top thing. Here you can see the dog bite, and this discharging sinus is communicating. So from an apparently small wound, as you start dissecting, you will realize the subcutaneous tissue inside is all dead. Fascia inside is all dead. And that is why the debridement has to be, these are the photographs of progressive debridement in the same setting. So I started off with a small wound, excision of the small part of the skin, and then went on increasing till I was reasonably sure that I have all these edges which are bleeding. And then, of course, with VAC, and this is post-skin grafting, this is after a few months. A similar case, again here you can see you think it is involving only this area. But once you start exploring, you'll realize that a large amount of skin is necrotic. This is what had to be done, and this is post infection setting. So in about 15 cases of necrotizing fasciitis, we had 3 mortalities. And even rest, they were just touch and go. Many were just touch and go. This man presented to us at 10th day. He was admitted in the hospital for 10 days. Some local debridement was done. We kept on debribing, but unfortunately, we lost him. These are some very nice papers on red flags in necrotizing fasciitis, differentiation between fasciitis and cellulitis with the MR imaging, and we will send these papers to you. So to conclude, friends, this is a medical and surgical emergency. Don't have antibiotic-free intervals. Start broad-spectrum antibiotics at earliest moment you even think of necrotizing fasciitis. Timing and extent of doing first debridement will decide whether your mortality and morbidity decreases. Remember, while doing debridement, you need to explain to the patient that it is likely to have spread in deep tissues, and the extent of skin excision is very, very likely to be much more than what is seen from outside. Salvaging tendon sheath is important, and therefore early skin cover is important. Negative pressure therapy plays a very major role in this, and unfortunately, the mortality is quite high if explode lead. Yes, friends, I am open to questions while Dr. Menon loads his presentation. He will be discussing on imaging in soft tissue infections. So if there are any questions, I'll take them. Otherwise, Dr. Menon will start.
There are no questions in the chat box.
Okay.
Okay, so I'll start this talk on MRI findings or radiological findings in soft tissue infections. What we will be covering from this excellent article which we'll share on the group is three main things that we are going to discuss today: cellulitis, necrotizing, and pyomyositis. Sir has already shown us a lot of cases of necrotizing and how critical it is to identify them early and then do an aggressive debridement to try and salvage, because mortality rates can be significantly high. And a lot of these patients come to us with a delayed presentation. So identifying them has two aspects. One is the clinical aspect, and second is the radiological aspect. Now, for that, I'll start off with the normal soft tissue anatomy, with going back to our first year. Our skin is composed of epidermis, which is the outermost layer. Then comes the dermis. Then comes the hypodermis, which is also the subcutaneous layer, which can vary from hardly a few millimeters in an elderly patient to few inches thick in an obese patient. Then comes the deep fascia. Now here I've left out superficial fascia because anatomists and surgeons and radiologists tend to differ on the definition of superficial fascia. Clinically and radiologically, superficial fascia is not very significant. What is important for us is to differentiate superficial and deep. So the epidermis, dermis, and subcutaneous layer becomes superficial. Then comes the deep fascia, which is an interval between the muscle and the superficial. So deep fascia forms the first aspect of deeper structure. So deep fascia surrounds the entire arm and the leg as well. It sends septae within the deeper compartment between muscles to form the intermuscular fascia. So deep fascia has two parts: one which encases the entire periphery, as well as the part which dips between the muscles, forming the intermuscular fascia. And then comes the muscle. So any infection in the upper three layers up to the subcutaneous tissue forms what we commonly see as cellulitis. We see a lot of it with redness, warmth, edema, especially in diabetics. And there are skin lesions like a routine boil, like a folliculitis or a furunculosis, which comes more under the medical or dermatological aspect. For us, cellulitis is the most important thing as surgeons. Then comes the deep fascia or the intermuscular fascia. An involvement of this region forms something known as necrotizing fasciitis, which is what Sir had discussed. And the third entity is an involvement of the muscle itself. An intramuscular abscess is what is defined as a pyomyositis or tropical myositis. So that is how we anatomically differentiate these three infections from superficial to deep. Now, one must understand is these are all theoretical definitions. Clinically, ultimately, it's one layer going from the skin to the subcutaneous tissue to the deep fascia, and infection can spread vertically. So in the same patient, you may have regions which are cellulitic, that is up to only subcutaneous, and in some parts, it may dip down into the intermuscular compartment and form necrotizing fasciitis with areas of muscle necrosis. So depending on the extent of infection, the duration of infection, each patient may have a variety of all three of them at the same time. How do we identify them? The first and most important thing in radiology is understanding normal imaging. So MRI, we're going to discuss two or three images sequences. One is T1, which by definition describes normal anatomy. So fat in T1 is white. You must remember that, or hyper intense. Muscle looks gray and fluid or necrosis looks black. Now necrosis is not normal, but in T1 image, necrosis or any fluid within the vessel or CSF fluid in the spine would look black. So we must remember normal. If fat is white, muscle is gray, and fluid is black in T1 image. Going to a T2 image, fat still remains white. Muscle still remains gray. What changes is fluid. That is how we identify spine MRIs. The CSF looks white. Even necrosis or anything abnormal, edema, is bright. So anything that you see bright on T2, our signals should be high, that this is abnormal compared to the normal tissue. So fluid or necrosis is white on T2. Now the radiologists have created one more image where the fat is suppressed. Now fat, even in T2 is white, T1 is also white. So what they've done is they've suppressed the fat, or T2 fat suppressed, or also called as stir images. There is another variation called proton density images. So all of these suppress fat, make them gray. So what stands out from the fat Whatever is white is your fluid necros. So that is how they've created fat suppressed image, so we can see fluid more easily. So revising this, fat looks white on T1 and T2, that's normal. In fat suppressed image or a stir image, fat is suppressed, so it becomes darker, it becomes gray. Muscle is gray throughout, unless there is something abnormal in it, it will look gray. If you see white in muscle, white signals, that means there is something wrong. Fluid in T1 is dark or black, in T2 is white, and in fat suppressed image also it is white. So if you see the right hand side column, the fat suppressed image, fat becomes suppressed. So if there is cellulitis or any edema, the fluid will stand out and the fat will be suppressed. That is why we use fat suppressed. And a lot of sequences we see stir imaging. We don't see T2, we see stir imaging. So moving on to the first and the more commonest entity that we deal with is cellulitis. Looking at an MRI of cellulitis, one is the clinical picture: redness, edema, swelling, warmth. When we do an MRI, what we get on T1 is the normal fat, which is white, becomes dark, hypointense. So our signals should start. We should start thinking there's something abnormal. On the same sequence, we can see. I'll try and highlight this here. Okay, this is normal muscle, normal fat, and here is hypointense fat, that's abnormal. Muscle is gray, which is normal, and any fluid or necrosis you'll see in subsequent images looks black. Sorry. My screen is frozen. I'm sorry about that. Yeah. Okay, moving on to T2. Now, specifically here, I've shown you T2 suppressed image, a fat suppressed image. Because in a regular T2 image, the entire fat and fluid, everything would look white. So that's the advantage of using a stir or a fat suppressed image, where the fat gets suppressed, becomes darker, and the fluid becomes white. It stands out. So it helps us define. You see these white strands here within the flat globules, which are grayish. This is the edema fluid. And this shows that it's just in the subcutaneous area, it is a cellulitis. Now, some of it may track into the intermuscular plane, but a little tracking into the intermuscular plane does not mean it is necrotizing fasciitis. What is necrotizing fasciitis? I'll tell you in the next subsequent slide. But a few signals going here, but not extending too far beyond, does not mean necrotizing. It is predominantly cellulitis. Moving on to fluid, identifying fluid on T1 and T2. On the left-hand side is a T1 image. Fluid is black, as we can see, on the both arrowheads, laterally and medially. Whereas in a T2 image, this fluid will look completely white. Now, how do you know whether this is a hematoma or pus? When we give contrast, contrast will go wherever there is blood. So if it's a hematoma, everything will be white. Whereas if it's an abscess, the center is pus, which doesn't have any blood. It will be low in intensity, and the peripheral surrounding tissue will be white enhancing. The lining of the abscess will be white. So that's the advantage of doing a contrast image in addition to T1 and T2. So here we can see T1 image on the left hand side, where everything is, the abnormal tissue is black here. Whereas you do a contrast image, the white structures that stand out is the fluid, because fluid is where the capillary is leaking out into the fat and stands out on a contrast image. In comparison, whenever you have a patient of chronic heart failure or renal issues with chronic edema of the feet, when you do a contrast image, there is no inflammation there. It is just stasis. So there is no enhancement. A lot of patients, for various reasons, we cannot do MRI. They may not be fit enough to undergo an MRI. A CT scan is a very quick, sensitive imaging that can be done and is more easily available than an MRI. So on a CT scan, what we get is infiltration of the subcutaneous tissue. If there is a collection, the center will be low and the surrounding tissue will start enhancing, showing us that there is a collection which could be a localized abscess along with the cellulitis. Moving on to necrotizing. Now, necrotizing is something that we can identify on ultrasound. An ultrasound will tell us whether the subcutaneous tissue has gone into the deeper intermuscular planes. The gold standard is in MRI. Unfortunately, in a lot of necrotizing fasciitis patients, the creatinine is high. So the radiologists calculate the glomerular filtration rate. If the GFR is normal, contrast can be given. But if the GFR is less than 30, then contrast is completely avoided. In moderate cases, the contrast dose may be reduced or diluted and then given. So that is left up to the radiologist. As orthopedic surgeons, what we must write is MRI with SOS contrast and leave it to the discretion of the radiologist to decide whether MRI will give any additional information. I mean, a contrast will give additional information or whether it is contraindicated in that patient. So the hallmark of necrotizing is high T2 signal. In T2, if you remember, fluid is white. So you see the deep fascia and the deep intermuscular fascia. If that's high or white on T2, that is an indication of necrotizing fasciitis. And it is not just high signal. It has to be thicker than 3 millimeters. There are a lot of patients post-traumatic, even with cellulitis, some edema fluid may seep into the intermuscular veins, but there's no thickening. Thickening is what differentiates, and the extent of involvement is what differentiates necrotizing from cellulitis. And necrotizing by and large involves a lot of compartments. By definition, it is 3 or more. But like I said, there may be areas of necrotizing in one patient restricted to a certain area, and the other areas may be cellulitis. Whenever we can give contrast, the contrast in a lot of necrotizing patients gives a mixed picture. If there is necrosis, now necrotic tissue will not have any blood. So that area will be non-enhanced. Same way as we see tumors, necrotic area in a tumor will not enhance, whereas wherever the contrast is extravasated through the capillaries, because the capillaries are fragile, will show high or white intensity. So that will show contrast enhancement. So there will be by and large a mixed picture of enhancement wherever there is seepage of the contrast through the blood vessels, and non-enhancement wherever there is necrosis or an abscess like pus. So this is a picture which shows the white arrows show deep fascia, which is involved circumferentially with white hypersignals. The white arrowheads that we see in the center show how the edema fluid has seeped in between the muscles and is much thicker than normal. It is more than 3 millimeters thick. It is clearly a V-shaped structure which is going in. And also the circle indicates muscle edema. So a lot of these patients, because of the significant swelling, the muscles start showing reactive inflammatory change. Doesn't mean that the muscles are necrotic. If we see hypointense signals along with this, then yes, there may be areas of muscle necrosis as well. If we can give a contrast, that will give us better imaging. But otherwise, in necrotizing, especially severe infections, whenever we explore, we must always look at the muscles, even though the MRI is normal, because the initial phases when the muscle is edematous, some of it may start necrosing. And that, when we open surgically, is something that we must excise, because necrotizing fasciitis can blend into pyomyositis. And patients who are presented late can have both necrotizing as well as pyomyositis in the same sitting. So this is a case of pyomyositis, where we differentiate just muscle edema from an intramuscular abscess. On the left-hand side is a T2 image showing the muscle is completely white. This is a biceps muscle which is completely white. So it will tell us that there is edema in it. There is something going wrong with the muscle compared to the other muscles which are gray. When we give a contrast, we can see a center hypointense area. Hypointense means the contrast is not going there. It means there is no blood there. That means it's an abscess or an intramuscular collection. Surrounding that, we get a white halo. That means that is the inflamed muscle which has a lot of blood supply. And centrally, it has necrosis or liquefactive necrosis happened. So that is a classical picture of pyomyositis. So going back and to summarize this, our tendency is to try to remember the characteristic feature of each diagnosis. What we must try and remember, like we do in pediatric trauma x-rays, is we try and see the normal. If you remember the normal elbow epiphysis, we'll be able to identify abnormal. If you remember normal anatomy, we know what is abnormal. Similarly, we must remember normal signals on MRI. Fat looks white on T1 and T2. It looks gray on fat suppressed. Clearly, the name gives it away. Stir or fat suppressed, fat will be gray. Muscle is gray throughout. If you see white signals in a muscle, that means there is something abnormal there. One entity that we see a lot of times in India is viral myositis or diabetic myopathy. there as well the muscles will be edematous. So contrast there will help us identify whether it is just edema or there is some necrosis along with it. Fluid on T1 is black, remember CSF. On T2 is white. Fat suppress image will suppress the fat, but the fluid will remain white. And whenever we give contrast, wherever the contrast goes, that means blood is going, those areas will remain white. Wherever there is necrosis or an abscess or a sterile fluid like a bone cyst, the contrast cannot enter that and there will be non-enhancing areas. Thank you.
Thank you very much, Dr. Menon, for very enlightening talk. Are there any questions now? Are there any questions?
Not on the chat box. If there are any questions, you can unmute and ask us.
Yes.
I have a question or a suggestion. Hello?
Yes, sir.
Yes, sir.
So
Yes,
it is easy in an institution to order a MRI or CT scan. Patient can be transported quickly and brought back. Not much time is wasted. But in setups where MRI is not in house, would it not be very risky to send a patient for you're suspecting necrotizing to transport him to another center for MRI and bring back? That would be too risky, isn't it? Or would you take that risk just for diagnosis?
So would you like to take that? Or should I?
Yeah, go ahead. In fact, any role of ultrasound?
So ultrasound is a quick and very easy investigation to do. So an experienced musculoskeletal ultrasound specialist or somebody who's done a lot of peripheral ultrasounds will be able to tell us the difference between cellulitis and necrotizing fasciitis. Even sometimes areas of abscess within the muscle can be picked up. Having said that, it is not as sensitive as an MRI. So at the first hint of a patient being unstable, or if we feel that it is necrotizing and these MRI or CT scan is not available, it is best to take the patient up for surgery rather than delay surgical intervention. So if there is discoloration of the skin, discolored blebs, hemorrhagic or purulent blebs, pain out of proportion, neural symptoms with abscesses pressing on surrounding nerves, these are all indications that we must go in rather than depend on investigations, maybe expensive or even not available. So nothing changes the clinical judgment.
Yes, just to continue that, somehow my experience with ultrasound in these conditions has not been very satisfactory. We have not had very, very useful, I wouldn't say not very useful, but they didn't contribute much post ultrasound. Finally, it is the clinical judgment. So either we do an MR or we go ahead clinically and explore.
If a sonologist is interested in musculoskeletal, he is going to help.
Yes, sir. Again,
Quickly done. It's also portable machines. So and this available in even smaller setups. So my first investigation would be ultrasound, and otherwise I would go more with the clinical judgment than send a patient to another center for MRI or CT or something.
So my input is, today ultrasound is not portable. You need to send them to a center. Portable ultrasounds are banned now. So end of the day, we are not going to have a bedside investigation. You will have to send to a center. Then it's your choice whether you would subject the patient to MRI, where he will be in a gantry for half an hour, 45 minutes, where he's not supposed to move and he cannot be monitored well. Or, of course, a reasonably quick open investigation from an ultrasonologist, which may not contribute much, but which will give some hint, is something which the treating surgeon has to decide. But portable ultrasounds are not there, sir.
Okay.
And
CT, CT is quick. So would you settle for a CT if choice between MR and CT and patient is fairly critical? Would you settle for a CT or wait for 45 minutes in gantry with this patient?
I would possibly go in for a CT in these cases, but cases which are really critical, I would go ahead on clinical basis and explore.
Okay.
I will not wait for a confirmatory diagnosis.
All right.
It's
So,
only when the sorry.
no,
Yeah, go
sorry,
ahead.
sorry.
Go ahead, Aditya.
Okay, so to answer your question, sir, I mean, there is one patient right now under our treatment who came with suspected necrotizing with a small incision to drain a compartment syndrome with an exposed tendon, and a little bit of pus was pouring out. She had a pacemaker put in 2 weeks back, so we could not do an MRI. There are MRI compatible pacemakers, but we didn't know the make and the company. So we did a CT scan, which did give us some information that there was a collection inside. It was not as sensitive as an MRI, but if it's available, it is better than just an ultrasound. And it took us 5 minutes, so it didn't waste the surgical, it didn't delay the surgical intervention. So it gave us information as far as deeper collection was concerned. So where absolutely contraindicated or not possible, CT is better than just an ultrasound. But again, if there is a delay, like you have to send the patient to another center, patient not stable, then clinical acumen is, I mean, nothing replaces that.
So people who are in institute, very often these patients come with small nicks done outside. So they are not necessarily very toxic because some part of it is already drained. In those cases, an MRI would be useful. Then it is worthwhile sending to a center. But of course, as I said, most important is clinical. Maintaining, life is the most important thing. So very often we have explored by just clinical judgment, on just clinical judgment. Shall I, sir? Go ahead.
Yes, I think that is adequate discussion on
Yes.
the imaging part.
Okay. Now, very often there are conditions which overlap over one another, as Dr. Menon said. So how do you know whether it is cellulitis, whether it is necrotizing fasciitis, or a deep abscess, developing deep abscess? It's a very challenging situation. I'll just illustrate with one case. Elderly female, hypertensive, chronic renal disease, came in with pain, swelling, redness of the leg on 7th day. She had difficulty in walking, she had blisters, there was no fever, but this is how she came. The limb was edematous, warm, it was tender all over. There were small hemorrhagic blisters. Distal pulses were palpable. We really didn't know whether we are dealing with necrotizing or we are dealing with cellulitis. So here you can see there are small blisters, but generally there is a decent line of blisters ending. What are the blood tests? CRP had increased, but not more than 150. WBC count more than 15,000. Hemoglobin less than 11. Sodium low. Creatinine high. So all this suggested necrotizing fasciitis. But clinically, we felt that this is not necrotizing. The lesion appeared quite superficial. So we started on present tizobactam. Now, what are the other scores? Are there any other scores? So here you can see it is 7, so more likely to be necrotizing. We did an ultrasound as Dr. Thakur suggested. There was no evidence of DVT because we were thinking that this could be DVT also. There was fat standing and there was only subcutaneous edema. The deep fascia appeared normal. So in this case, MRI, we did not do an MRI, but we did an ultrasound. We did an MRI which suggested cellulitis. Now, what do we do? Do we operate? We don't operate. Now, if we have to operate, there has to be some localized thing. There is nothing localized. This is not necrotizing. So if at all, she would need very extensive debridement if we go just by clinical. So we just waited. Observe daily and let us see how she progresses with a very clear thinking that if need be, we explore at a moment's notice. So this is day 2. You can see she has started forming wrinkles. Sorry, started on the antibiotics, elevation, max self, wrinkles over the ankle. This is day 3. The edema is slightly less, erythema is less. Day 5, warmth significantly less. But now here you can see she started developing a small swelling there. But otherwise that erythema has gone down significantly. In 4 days time, her CRP dropped from 96 to 48. Her counts dropped from 19,000 to 9,000. Her hemoglobin, which had gone down, started increasing. Her creatinine from 3 came down to 1.4. So she was very closely observed clinically and hematologically. And we were sure that we are not dealing with necrotizing fasciitis. And over a period of time, she started developing a small swelling here. Localized swelling over the distal tibia. So you can see we did an ultrasound, we did an MRI, we did not pick up an abscess. Over a period of time, she formed an abscess, which very proper fluctuation with a diagnosis of a soft tissue abscess. And here you can see we drained the abscess, a localized thing, and she settled. So as I said, red flags for necrotizing fasciitis. There is a very nice paper which we will share with you. So these 3 things, cellulitis, necrotizing fasciitis, and developing abscess, may simulate each other and need to be observed very, very carefully, very tight observation. These 9 flags, the author have suggested. History, 3 flags. Physical examination, 6 flags. So history, pain out of proportion, diarrhea, and any kind of surgery in previous 90 days. 1 point each. Physical examination, hypotension, altered mental status, erythema progressing beyond marked margins. In the sense, you keep marking the erythema margins. And if they are increasing, then you give 1 point. Zinc fluctuance, hemorrhagic bullae, and skin necrosis. If more than 3, it is almost likely to be necrotizing fasciitis. Another mnemonic called phones for surgical doctors. Again, various criteria are put in. Whatever it is, what is important is a good clinical examination, appropriate blood investigations, appropriate imaging, and it is best that you go yourself to the center or to the ultrasound machine and discuss ultrasound department and discuss with the ultrasonologist what you are actually suspecting. That goes a long way in diagnosing this. Thank you, friends. Any questions?
See, forming abscess is a process under observation. So when you are faced with a case where you are suspecting cellulitis or deeper thing, now one would really has to wait and watch and see. That means clinical judgment.
Yes.
Not every infection under the deep fascia would be necrotizing fasciitis. There could be a simpler infection under the deep fascia as well. So the abscess location, superficial or deep to the fascia, could not be a predicted thing. depending on where the infection is, where it got localized or not, one would have to take call that abscess is there or not there. Do you think any infection at the facial level is to be treated as necrotizing?
Not at all. I mean, here, that's why I showed that we did not address it surgically on day one. We kept on observing. We felt that this is not necrotizing. Though the scores were equivocal, could be this way or that way.
Yeah.
We did not operate. We waited, observed carefully, and then she turned out to be a simple abscess. So these things do merge into one another. There is an extreme where you are day one, you are sure that this is necrotizing fasciitis. There could be a case which needs to be observed like this and treated by a very small thing like a IND. Or sometimes they settle without any surgical treatment. Many cases of cellulitis just settle with antibiotics.
Sure.
So all I'm trying to stress is very careful observation, number one. Number two, marking the margins. And number three, photographs every day. If need be, twice a day. And see serial photographs. Otherwise, it becomes very, very difficult to know what is happening. So by tight observation, I meant this. Margins, photographs, hematological investigation, and keeping a chart of hematological investigations. That in all will be observation, under observation. Anything else? Anyone? Any questions? If there are no more questions, yes.
No,
please.
there are no questions.
Okay. Then I'll go ahead with another very challenging situation called pyomyositis or tropical pyomyositis. So it is essentially an acute bacterial infection of skeletal muscles and results in localized abscess formation to start off. And then it can lead to several things. There can be multiple abscesses in the same muscle or abscesses in multiple muscles. The most common organism is Staph aureus. There is something called acute bacterial myositis. And people claim that these two are two different things. This means infection within the muscle with inflammation extending through more than two muscles, but without abscess formation. That little confusing things. End of the day, for all practical purposes, these are similar entities as regards treatment is concerned. They were popular. This was popularly known as tropical pyomyositis, thinking that it occurs only in temperate zones. It is said that in Uganda, 4% of all hospital admissions are pyomyositis. In Ecuador, 2.2% of all surgical admissions are pyomyositis. They're that common. But in other areas also, they are common or becoming common, more so in immunocompromised patients like HIV, diabetes, leukemia, so on and so forth. And the most commonly involved muscles are large muscles: gluteus, quadriceps, pectorals, iliopsoas, gastrocnemius, so on and so forth. They're generally large muscles. These signs may not be classic, and therefore it simulates many conditions. And all in all, many orthopedic surgeons are unfamiliar with this disease, and that leads to many problems. What is the cause? It is a little funny that skeletal muscle, which is intrinsically resistant to bacterial infections, gets infected. There are several experimental studies, several clinical studies. Staphylococcus septicemia, you will hardly find abscess in a muscle. In fact, it is said that you directly inoculate the bacteria into muscles of dogs, Staphylococci will not produce an abscess. So therefore, generally, these patients will give history of blunt trauma or vigorous exercise of the involved muscles or IV drug abuse. it is said that after trauma, there is an abundant iron which favors growth of bacteria. Otherwise, they are very, very unlikely to form bacterial infections. So what is the pathology? Initially, it is just edematous separation of muscles. It can develop to patchy myocytolysis. Now, this is a very interesting slide I found. Here you can see these are the normal muscle fibers. And these are the muscle fibers where you will see vacuole formation. You can see in the muscles there are vacuole formation. This is often reversible, but often progresses to a complete degeneration. And that is what happens in pyomyositis. Generally, it is in 3 stages. The first stage is invasive. Generally, they have fever. There is a painful firm swelling, minimal systemic symptoms, and if you explore at this time, you will not find pus. And it is likely to resolve by itself. While the second stage is when the abscesses form. Generally between second and third week. Now, there could be an abscess inside. This is something very common in quadriceps or iliopsoas. From outside, you will have an apparently normal muscle. So the abscess is deep inside. You may not have fluctuation. You may not have fluctuation or edema. But deep inside there is an abscess, and that often is confusing. But here, pus has already formed, so drainage or aspiration would yield pus. And the third stage is dissemination. If the abscess remains untreated, then after about 2 or 3 weeks, the infection can lead to septicemia and can lead to anything. Imaging, ultrasound, enlargement of muscle. The muscle appears swollen with or without abscess formation. Ultrasound is very useful in case you feel that an ultrasound guided aspiration is needed. So ultrasound plays a very major role in pyomyositis. Sorry. Pyomyositis more than the necrotizing fasciitis. MRI, though, is investigation of choice. Dr. Menon has already described this. There are several conditions which produce similar things. Contusion of muscle, septic arthritis, osteomyelitis, infection anywhere, of course, or trauma can have a similar finding. Very often there could be a muscle rupture that produces similar thing, and therefore proper diagnosis is very, very important. And all in all, as I said, awareness should improve because it is a potentially life-threatening wound, but a completely curable condition. Life-threatening, but completely curable. Timely incision and drainage play a very major role. And the difficult is to decide when to explore. So, Dr. Menon, if you can share your screen, this is some basic things about pyomyositis, and Dr. Menon will share a few cases.
Thank you, sir. So to take it from where sir has stopped his presentation, we'll discuss a few cases of pyomyositis. So this is a 46-year-old gentleman who came with pain, severe pain and swelling around the left elbow, with a history of local steroid injection 8 days back, no comorbidities. The ultrasound showed an abscess, and we decided to explore it. The brachioradialis appeared extremely tense. The minute we took an incision, we can see this bulging yellowish necrotic muscle, and there's frank pus within the brachioradium. It's a classic pyomyonecrosis. It's a bulging muscle with abscess the minute we open the muscle sheath. There was pus within the biceps as well. So a simple local steroid injection probably has given rise to this complication. Very, very uncommon, but once we see this clinical picture, there is no role for anything other than surgical intervention followed by the right antibiotics. The cultures grew MRSA because it was resistant to oxacillin. So the symptoms continued. There was pus pouring out from the wound, so we explored again. The minute we explored, we realized that we had to excise a part of the biceps and brachialis. This is what can happen it's a continuous process of necrosis even after the debridement till the appropriate antibiotics are started. The process of necrosis continued, and that is why the symptoms still persisted. So we re-explored, put in simulant beads with vancomycin, and then closed the wound. And this is his range of movement at 3 to 4 months of follow-up. The next patient was a 55-year-old male, came with high fever, severe pain in the right hip and thigh for the last 5 to 6 days, diabetic, smoker, chronic alcoholic, the works. It was extremely uncomfortable. The X-ray showed soft tissue signals, nothing more than that. This is the area that we marked out clinically, areas which showed significant pain. We marked the pain score as well on the thigh. This is something that we've developed over a period of time. It gives us a clinical idea as to where could be the area of maximum infection. So in this case, it was along the posterolateral aspect of the thigh and the adductor region. What we also do and is take a video which tells us, so the patient is talking and telling us, we explain the VAS score to him. So he says it is 2 on 10, 8 on 10, or it's very severe. So we get an idea as to which is the area of maximum tenderness. So that's how we record all the regions, mark out with a pen, with a marking pen. And he was very, very clear that the infection, the pain spread along this medial aspect. And you can see him pointing out that this is the area on the posterior and posterolateral aspect that was extremely tender. Patient was significantly wincing with pain the minute we pressed that area. And the intervening area was absolutely normal. The MRI ordered subsequently showed a hypo-intense signal in the adductor region, the obturators, which was hyper-intense on T2 with no obvious bony involvement. The contrast enhancement showed an abscess. Diagnostic of pyomyositis. The investigations by then had come back. HbA1c was above 11, touching 12 almost. Blood sugar was extremely high, it was 388. Albumin was very high. So we planned, obviously, for an emergency exploration. There's no, question about that. But the minute we took the patient up for OT, the anesthetist just brought the roof down that this patient is in ketoacidosis. If we intubate him or anesthetize him, he will never come out of anesthesia. So optimize this patient, get the sugars in control, and then operate. Now, a patient who's got frank pyomyonecrosis, we can't leave him just like that because the antibiotics are not going to reach the abscess. So what we decided is to do an ultrasound-guided aspiration with a wide bore needle. Dr. Anirudh Kulkarni, who was an interventional radiologist with us then, could aspirate even the collection of the biceps from medial entry. We felt that the abscess is drained, patient will be very happy. We're done with it. Now that we have the abscess, we can start antibiotics, and we probably don't need to do anything. The next day, we went to the ward, and the patient was extremely uncomfortable. He was in very severe pain. Said, please do something about it. So we repeated an ultrasound here, and the ultrasound said there is no collection. There are areas of hypoechoic muscle, but no evidence of any organized collection. But he had radiating pain, flexion deformity of the knee, marked tenderness. Any attempt to extend the knee was extremely painful. So we decided to explore. In spite of what the ultrasound said, we must explore, and by then the patient was optimized. So we took a medial incision along the adductor region, along excising the area where the needle for aspiration was passed. There was minimal collection there. Most of it had come out. The posterolateral incision was taken on the area where the patient had maximum tenderness. You could clearly see again a yellowish swollen muscle. The biceps femoris was necrotic, and there was some small opening with discharge pus coming out. The minute we opened it, frank pus started coming out from that area. There was a thickened sciatic nerve right underneath that, and that was the reason the patient was so uncomfortable. And it's not just a thickened nerve. What we found was a thick membrane which had formed over the nerve. So the abscess just kept on forming layers and layers, and the nerve was getting entrapped over there like a impingement. And that is why the patient has radiating pain with a flexion deformity of the knee. The hamstrings were completely in a spasm. So we excised this entire membrane, removed the necrotic muscle, drained the pus. The cultures grew staphylococcus, which here was methicillin or oxacillin sensitive. Started on injection fluoxacillin. Settled extremely well, very comfortable. So what we learned from this case was pyomyositis does run an acute course at times. Whenever the patient is clinically not stable or not fit for anesthesia, try and reduce the burden of infection by doing an image-guided aspiration. Clinically, we must judge, we must not rely only on ultrasounds, or even sometimes even CTs and MRIs in the early stages can be difficult to interpret. So we must assess each case clinically and then take a decision based on that. Moving on to the next case, this is a 31-year-old gentleman. He had a fall from a scooter on 10th of May, sustained an injury to the right elbow, had pain, difficulty in lifting weight, settled with NSAIDs. But in the next few days, the pain kept on increasing, so much so that he got an X-ray done which showed a radial neck fracture, given an above elbow cast using Scotch cast or the trying cast synthetic material. The pain significantly increased after the application of the cast. So the primary surgeon univalved the POP so as to reduce the tension a bit. Next day, the pain was unbearable. He went to another surgeon. He bivalved. The other surgeon bivalved the plaster, but the pain persisted. Fingers became dusky. There were diminished sensation. So, a diagnosis of compartment syndrome. It was obvious clinically that the patient now had a compartment syndrome, and a decision was made by the surgeon to release the compartment, which was absolutely correct. So, 31-year-old with no comorbidities was planned for a compartment syndrome for a tight plaster followed by swelling. Blood test was said, counts were 25,000. That means there was something going wrong within that compartment. Creatinine was 1.6, probably going into rhabdomyolysis. And these were the images sent by the surgeon who released the compartment. The fasciotomy was done, noted to have a large abscess. Now, this is a video which was taken during the surgery. This is the elbow crease, and the minute the surgeon put his fingers proximally into the arm, frank pus was draining out. Almost 200 cc pus was drained and sent for cultures. By then, within a few days, WBC counts had increased to 52,000 cultures grew streptococcus, started on IV antibiotics, planned for redebridement. The bed looked clean, they could close it, but unfortunately, by 23rd of May, another few days down the line, he developed severe pain. They got an MRI done, which was indicative of necrotizing fasciitis as well as myositis of the arm from the elbow up to the shoulder joint. Massive areas of cellulitis, fasciitis, and myositis, all of them together. So this was in one patient. Like I said during the previous talk, that one patient can have all the things together. This is a very good paper, which has also shown before, that necrotizing fasciitis can involve muscle subsequently and they can coexist. So by the time the patient came to us, there was marked swelling in the forearm, anterior chest wall, scrotal and penile edema. That means there were systemic signs of infection in this young patient. Marked tenderness along the anterior chest wall, biceps. There was a mini vac in situ from the primary surgery, and that wound had given way. So radial pulse was well felt. Finger movements and sensations were good, but the WBC count showed 28,000. Yes, it had gone down, but it was still high. But in view of the severe swelling MRI findings, we decided to explore immediately. And there were obvious signs of sepsis because of the penile and scrotal edema. This was the wound before opening. The vascular bundle was exposed and covered by a necrotic sheath medially. So the challenges here were obviously we need to salvage the life. In addition, try and salvage the limb. Control that could be achieved by controlling the infection with possibly resistant bacteria by now. Cover only and only after we've got adequate infection remission, we've got a clean bed, and then think about the function. So the minute we opened, we found necrotic brachialis muscle, long head of biceps. The medial intermuscular septum along the neurovascular bundle was completely necrosed. We had to piece off the septum layer bit by bit so that we didn't harm the neurovascular structures there. Long head of triceps was necrotic. Pectoralis major and coracobrachialis looked okay. And the fascia on the lateral side of the arm was also necrotic. So, it was a clear case of massive infection which had spread along the neurovascular bundle, right from the forearm up to the axilla. And we can see this forceps and we drain the abscess from within the axilla. So, for day one, because of such a large wound and we had freshly debrided, decided not to apply negative pressure wound therapy because it could result in significant blood loss. So at this stage, we did not explore the pectoralis minor because we felt that we had drained enough fluid from there and there was no obvious necrotic muscle. Post-operatively, patient was very comfortable. A lot of times we do see WBC counts jump immediately after surgery. So that's a trend we must monitor. Then we took the patient up for a redebridement negative pressure wound therapy with clenched choice foam was planned. Now the challenges are, it's a large wound. How much pressure should we keep? Because it can suck out all the blood. There's a vascular bundle there. We put a foam directly on the vascular bundle. When you remove it next time, it can actually shear off the vessel. So we put in medicated gauze like Bactigras or you can put Vaseline soaked gauzes on top of the neurovascular bundle and the bone. Applied a burn mesh like a wound contact layer so the foam does not stick to the underlying structures. This is a clenched choice foam which enhances wound healing, increases granulation tissue, and provides installation of saline into the wound. So it's like a wound wash every 3.5 hours. Pressure was kept at minimum because we didn't want to suck out all the blood. I mean, we were always worried about that. The company person kept telling us, no, 75 is not adequate, keep it at 125. I mean, as surgeons, we know clinically what to do and what not to do. So we told him, no, we keep it at 75. We're worried about the neurovascular structure. We understand 125 is ideal, but we don't want to keep it. So the culture by now, we had expected something resistant. It was Acinetobacter resistant to everything other than minocycline. So extremely troublesome bacteria. So we kept on changing the canisters because the insulation fluid kept on going in. Hemoglobin kept on dropping instead of transfusion. Patient was not comfortable. Pain kept on increasing. There was tenderness over the chest wall. I mean, we thought we had done everything, but still the hemoglobin kept dropping. Pain kept increasing. So I mean, we didn't know what to do, where we were going wrong. The wound looked relatively good, but proximally there was a little bit of necrosis. So we extended the incision, and pectoralis minor by now had been necrotic. So probably when we had explored the first time, it was just the initial phases. By then, this necrosis was extended, and even the pectoralis minor had to be excised. And brachioradialis had edematous fluid in it. It wasn't pus, but it was bulky and edematous. So we were just not happy with the muscle bulk at this stage. I mean, generally we would be happy after 2 or 3 wax that things have started improving, but we weren't. So we kept the same pressure. If I decrease it from 75 to 50 because we felt the pressure was too much and maybe he is uncomfortable. But the patient next day was saying he was just not comfortable. He had not slept the whole night. So, I mean, what do? Do we decrease the pressure? Do we redebride or increase the painkillers? What we felt at that stage was whenever we put installation back, it's fluid going in. Now, whenever fluid goes in, it has to come out as well. But if the pressure is not enough to suck the fluid out, the fluid will keep contained, would stay inside the arm and cause more edema, more pain, more swelling. And that is what we have found intraoperative as well. So we changed the pressure to 125, and that is exactly what the company person, the dressing technician had told us. The minute we increased the pressure, within 10 minutes, the patient was very comfortable. So in effect, we were actually creating the compartment syndrome by not giving adequate pressure. So maybe on day 1, we should have kept it less. But the next day, once we were happy with the hemostasis, we could have increased the pressure gradually in the ward and monitored the output. The minute we did that, the granulation started improving. The vascular bundle was covered with granulation tissue. At this stage, Dr. Bimal Modi is a very senior plastic surgeon who will be joining us next week. Insisted that we do a partial closure, firm bandage to try and reduce the edema, reduce the side of effect, and reduce the extent of plastic surgery that would be required. So these were the stay sutures that were taken to bring the tissues close to each other. Pain reduced, WBC count started normalizing. The size had significantly reduced. So if you can see here, the bulk of the arm was much more, and with compression dressing, it had gone down. Muscles were healthy. Proximally, it could be closed. It's the middle area where the maximum skin excision had to be done, where a graft was required. Otherwise, everything else was closed primarily. So the extent of plastic surgery had significantly reduced. This was at 25 days, and this is at 6 weeks. We could salvage the wound because initially we ignored the input of the dressing technician, but the minute we remembered that, implemented it, things just changed drastically within 10 minutes. And this is at 4 months. Has restriction of movement, half the muscles are not there. but we could salvage the limb, we could salvage the life, and these are difficult cases where functionally the patient may not be ideal, but we try and get them back with rehab to as best as we can. Thank you. So, are there any questions on these few topics that Sir and me have taken? We can take them now or move on to the next topic.
Thank you, Dr. Menon. Very challenging cases. So what we are trying to stress is these are once in a while cases. We should be absolutely aware of these things because very often they are not treated appropriately. So are there any questions? Aisha, Upadhyay, Srinivas, Aniket, Hearn, Moutaz, Mukhtar Hassan. Anyone? You're there or not there? Please do unmute.
No, Dr. Aniket has written there are no questions.
Questions.
I mean, we understand these cases are exotic, so you may see them once in a while, but the idea is to try and remember the red flags and not miss the diagnosis.
Okay. Aditya, I think let's discuss tendo Achilles because then there would be better discussion on that.
Okay. So this was a series of cases which we recently presented at a conference, whether oncosurgical debridement and infected tendo Achilles ruptures in elderly diabetics can give good functional outcome without reconstruction. So once in a while we do get tear in tendo Achilles, and we understand that a repair of the tendo Achilles is through tissue or a layer which is relatively avascular or the vascularity is not ideal. And if they do get infected, they are extremely challenging. So I'll highlight a few cases which highlight the challenges and how we can.
Yeah, Aditya, let's open it to people. Have they encountered infection post tendo Achilles repair or rupture? Has anyone encountered infection of tendo Achilles post surgery? I'm sure many of you must have come across tendo Achilles repair, isn't it? Anyone?
No, sir, we haven't. I haven't encountered a post tendo Achilles repair infection yet.
Anyone else?
Sir, I have seen the case of surgical site infection after a repair of tendo Achilles.
Right.
Repair, sometimes a reconstruction, sir. Though it was mostly, sometimes it was serous to serous sanguineous discharge at the wound site. And apart from removal of few stitches and the local wound debridement, using just the normal available gauzes and all available in ward, we did not surgically explore them in OT. So, and the patients were usually discharged within a few days of the wound appearance being good. So I don't have long-term follow-ups as such. And out of the cases of tendo Achilles repair or reconstruction we have had in our ward, only 1 or 2 were got infected in the immediate post-op period. So long-term follow-up wise, I'm not sure, sir, but only we did the local debridement in the wards.
Okay. Anyone else has an experience? No, I think you can go ahead, Dr. Aditya.
Yes, sir. So this was 68-year-old diabetic. Had a road traffic accident with a wound over the tendo Achilles. So the wound did not heal and came at 4 months after the RTA with a non-healing ulcer. He was discharging pus from that wound, restricted ankle range of movement, and he was unable to walk. He was extremely uncomfortable. So we traced the history. These are the images that the relative shared with us. There was no debridement done elsewhere. Tried wound dressing, and the necrosis kept on increasing. We got an X-ray done which showed lytic area in the posterior tuberosity. MRI showed complete tear and retraction of the tendon with abnormal soft tissue proximity. Now, this video is extremely important because it gives us a clinical hint as to the extent of infection. What Thakur sir was saying is we may not be, we may not have access to MRI, but just a clinical test or a clinical examination can guide us as to what could be the extent of infection. The minute we squeeze the calf, we can see pus pouring out. It shows us that the extent of infection is not just around the wound, it is proximally up to the middle third of the calf. It's only a simple clinical examination. So whenever we are seeing a wound, palpate the surrounding areas way proximal to it and see if we can any exudate is coming out by squeezing away from the area to in the direction of the wound. So that gives us an idea along with the tenderness. The video where we showed we chart the pain on the limb and mark it out. These are simple clinical, there's no cost to it, and gives us an idea of what could be the extent of infection, and that way would help us plan our debridement. So the plan was to tide over the crisis. Like we've been stressing, get rid of the infected material, reconstruction, everything comes much later. So we cover it, give antibiotics, and then we think about the reconstruction later. So this scoop was put in, and the mark proximally shows us the extent of degloving that had happened. So that's probably where the pus had tracked. This is the long S-shaped incision that was taken, excising the scar distally. Again, if we don't have access to a plastic surgeon or we ourselves are not trained in covering, these are cases where we must ask for help, because it's obvious that after excising this sinus and this ulcer, we will not be able to close it. So there is no point in doing something if we know we will not be able to close it, or don't have the ability to do it. Then we must be, instead of doing a minimal work, we must make sure that we get the facilities or send the patient to a place where those facilities are available. So the entire infected ulcer was excised along with the posterior tuberosity, which was necrotic. There's frank pus under the tendo-Achilles, which was aspirated, sent for cultures. The entire gastrocnemius, leaving a margin of centimeter proximal to that, was excised till we got normal gastrocnemius, healthy muscle. So about 16 centimeters of muscle along with the tendo-Achilles was excised. That is the extent of infection that was there, which was obvious in the preoperative clinical video. So there is no point doing a half job. We must excise everything that's necrotic. Then we put in VAC, the granulation improved, cultures grew Proteus and E. coli treated with meropenem. We put in stimulant beads, and Morisa did a split thickness skin graft. So the aim was to control the infection, get a good skin cover. That is what we could achieve, and plan for a tendon reconstruction after wound healing. So we gave a 6 weeks below knee cast, then followed by partial weight bearing, followed by full weight bearing. And then we decided, let's see what to do. So the left image is 1 month. This is a video of the patient walking at 6 months. It was a little wary about walking normally, but he could do it without support, with a good lift off. And on the right hand side is a video of the same patient with 3 years. Very comfortable, walking normally. At every stage we felt that at some stage we must do a reconstruction to replace the tendo-Achilles, but the fibrosis and the soft tissue cover actually acted like a tendo-Achilles, and this patient could do everything that he could do even before the surgery. So it shows us it's a good debridement, getting a good soft tissue cover, treating with appropriate antibiotics can give us good functional results as well. Yeah. So, these are papers which stress the same, that we may not need tendon tear reconstruction after return to normal or near-normal activity. When the next patient came to us, he was a 51-year-old diabetic present with purulent discharge for months, treated elsewhere, with an open repair with vicryl and fiber wire in the tendo-Achilles. So tear rupture was treated with a repair. Unfortunately, got infected. There was a gap when we got the MRI done, it shows a severe retraction of the tendon, calcaneal osteomyelitis. And as in the previous case, we took a long incision, excise the ulcer, excise the necrotic skin, remove the fiber wire, the suture anchors, scrape the calcaneum, and excised the lower end of the gastrocnemius as well. She got a good wound bed. The gap was almost 6 to 7 centimeters. Closed the proximal part primarily, applied wax distally. Cultures grew MRSA, given lycoplan, skin grafting was done, and this was the wound status and the functional outcome. Patient had good plantar flexion. Patient could stand on the toes, and this was the video at 9 months. Same patient at 18 months. A video of her standing on her toes. So it shows that after infection, after getting good infection control with a good cover, the entire fibrosis itself acts like a tender Achilles and helps the patient do everything that he or she would want to do after surgery. Before surgery. So the third case, similar road traffic accident with a discharging sinus over the tender Achilles, calcaneal osteomyelitis. Now, calcaneal osteomyelitis is something which invariably happens with a long-standing tender Achilles infection, but it travels along the sheath and involves the area where the tender Achilles inserts. Cultures grew another gram-negative bacteria, Morganella, treated with ertapenem, and wound healed well. These are videos showing active plantar flexion against resistance, patient being able to stand on his toes. This is at 1 year, 4 months. And we looked at the functional scores of all these patients. It's a foot and ankle outcome score, 0 being the worst, 100 being the best. On an average, we got a score of 85.5, which is significantly good, considering that the tender Achilles had been excised and no reconstruction was done. The question is, are there any references for good function without any reconstruction? There are none. So again, will this work in young active patients who want to get back to sports? That's probably questionable. Maybe in those patients, we might have to think of reconstruction. But what we're trying to highlight is not just tender Achilles, any other area that we, wherever we're dealing with an infection, get a good infection control. Don't worry about the extent of excision. Get a good soft tissue cover. Give appropriate antibiotics, and we will achieve good functional outcomes by and large. Thank you.
Thank you very much, Dr. Menon. Any questions about this? So we have been stressing all along that do good debridement, good debridement, aggressive debridement, aggressive debridement. Why do we say this? Because nature has tremendous capacity to regenerate. Our body has tremendous capacity to regenerate. Now, I'm just going to show you a few cases here. They are extreme cases, one end of the spectrum, where nature has done magic. And I call it enjoy the magic of nature. They are rare cases, but now I am not discussing, since not many of you are likely to come across cases of soft tissue infections, I thought I'll show you these cases, which are our day-to-day cases, non-union cases and infected non-union cases rather. So this was a young patient, middle-aged person. He presented with Elizaro put on for 2 years. You can see there are multiple discharging sinuses here. This is the X-ray he presented at. This was biodegradable. These were, what are they called? For bone forming, these artificial bone substitutes. I traced his old X-ray. He had, at 9 months, he had infection with obvious signs of osteomyelitis. So somebody did Elizaro, and this is how he presented at 3 years. Now, the challenging thing where he was in Elizaro for 3 years, he could hardly sit. There were multiple discharging sinuses. All these external fixator pins had become absolutely loose, and it was very, very uncomfortable. So I thought the first thing I should do is aggressive debridement. So what did I do? I just took out the Elizaro pins, which just came out without any issue. You can see there are large areas here, but I covered the wounds or multiple discharging sinuses with a mop. With the mop rolled, made up just to cover the discharging sinuses, went on either side of the mop, superior, rather anterior and posterior, and excised the entire area with this. You can see these bone holes I have increased. Now question is, now what do I do? Because there is hardly any bone proximally which will allow me any kind of fixation. What do I do? I was thoroughly confused on. He grew gram negative bacteria resistant to everything, so I had to be started on colistin. This is how where I am. I just don't know what to do. So I put him in the Thomas's splint and discharged him. This is the X-ray 25 days. You can see he started developing callus. By 3rd and 4th month, he was using a knee brace, knee immobilizer, which is actually not stabilizing this fracture. Well, he's been walking. This is 3/12. 3rd month, you can see he started healing. 4/12, 4th month, you can see he's healing. He's able to lift up his leg completely. This is 6 months, a decent healing, and this is 2 years. Straight bone, completely consolidated, good range of knee movements and hip movements, doing everything at 2 years. Everything at 2 years. I have not stabilized him at all. I have not given him a plaster. I have done nothing. Just nature helped heal this. Another one, a young man presented with an osteomyelitis of 10 years and a pathological fracture of 6 months. This is the medial side of the thigh. These are the MRI images, X-ray and MRI images, where you can see there is a discharging sinus, signal abnormalities in the lower the femur. So all I did was excise the sinus, trace that sinus into the area of pathological fracture. And here you can see this is a middle segment that I have excised. The pathological fracture part is just excised. Then open these canals and scrape these canals here thoroughly. And this is him at 4th day. Again, I wasn't too sure what to do. I was planning an Elizaro, but I thought I'll scrape the canals first and then maybe come back at a later date. So this is him at 4th day. The wound appeared very good, so I thought I'll just put stimulant beads, and then in about 6 weeks time, not stimulant, Pama beads, and at 6 weeks time come back and do Elizaro. This is how I am. I put in beads. I put in beads all over. Since there was significant infection posteriorly also, I put beads posteriorly. And I thought I'll come back at 6 weeks and do Elizaro. He was just lost for follow-up. Just lost for follow-up. 4th month, he came in, you can see, walking like this. The beads are still in C2. So I decided to remove the beads. I couldn't remove the beads because the whole thing was absolutely covered, thickly covered with callus. This is at 8 months follow-up. Bone has started healing. He has been walking quite well. He has a decent range of knee movement. This is his gait. He does have a lurch, but walking reasonably well. Osteomyelitis of 10 years with pathological fracture 6 months. I haven't done anything except a decent or very good aggressive debridement. This is at 16 months. Does everything: motorcycle, jumping, running, squatting, sitting cross-legged, does everything. So this is just nature. All we are trying to say that we are not against infection, stabilization. Obviously, stabilization plays a very major role, internal or external. But these are extreme cases where fractures have healed without any stabilization. So if you aggressively debride and stabilize, you will realize that the bones will heal like anything. This is at 16 months. Another one. I don't know whether I have shared this case. Have I? Dr. Aditya? Have I discussed this case?
No.
Okay. So this was a open fracture presented at 3 weeks. You can see a large open wound. He came in with a culture report of Pseudomonas sensitive only to cholesterol. He has a comminuted fractured tibia with bone loss, a segmental fractured tibia, segmental fracture fibula. You can see something which we have insisted that avoid using just one planar fixator. Have a modular fixator, because otherwise you will not be able to get any kind of realignment. So we changed the fixator. You can see we created a delta frame, put rod-to-rod clamps, and got a reasonable alignment with a decent wound. So we nailed the fibula and achieved a good cover. Moment we did a flap, we had tided over the crisis and we had found a cocoon in which bones can grow. Now what do I do? We have a large defect here, but we have a decent skin and we have a fibula which has united. Now the patient was not keen on any osteotomy. He was extremely scared that he came in with Pseudomonas sensitive only to colistin. So he felt that you create another fracture, there would be a problem. If that gets infected, he said, I'll be in big trouble. So we decided to just shift the fibula. Just shift the fibula. The question is whether in an adult, it would form adequate bone, it would form adequately bone of decent size, which will allow good weight bearing. But the basic concept, remember, is bones generally form in case wherever there is a good casing. If there is good casing, bones will just occupy that place. So I have shifted the fibula. Within no time, sheets of bone started forming. You can see there is bone formation here. This fracture is, the fibula has started healing. When I shifted over to uniplanar fixator, orthofix type fixator, because that would help him walk comfortably. And this is at 4 years. Just shifting the fibula, most important, giving a good casing. So nature can really do wonders. Another one, large skin defect, large bone defect, just achieved cover, put a flimsy bone grafting with another flimsy support, tibia profibula graft. I really didn't know what would happen, but I have given a good cover. I have a cocoon, I have a cavity, enclosed envelope, and the bone should form. This is at 6 months, at 7.5 months when patient had started full weight bearing. This is at 12 months, this is at 4 years, and is at 11 years. So the bone just keeps forming if you give a good envelope. So bone just formed from nowhere to this. So it has been observed that if you do this, the fractures can just heal. So this is a very nice paper, controversial though, published by my professor, Dr. Kothari, Lopamehta and Natarajan. And they say that bone is like air in a tubeless tire. It gives rigidity and shape to that tire. In return, takes shape of the tire. It is independent and nothing is actually attached to the bone. Muscles, tendon, etc., etc. The bone just forms and all these things will get connected. So it just fills in envelope provided by soft tissues around. So in a non-union scenario, if you create an envelope with appropriate shape and maintain that shape and just add a small stimulus, a minuscule quantity of bone, it will hypertrophy. Obviously, it will not hypertrophy in every case without support or without bone grafting. But what is most important is creating a good, clean envelope without any infection. So these are extreme cases, friends. This is just to support the hypothesis. Doesn't mean, again and again, I am telling you that it doesn't mean that one should do flimsy or no fixation in every case, or we should purposely infect cases. But what nature can do is something we are trying to stress. So when you're dealing with these difficult things, think, plan, and attack, and that would help a lot. Any questions? There's nothing in chat box?
No, nothing on chat box.
Okay. So,
Dr. Aisha has asked, how do we transfer the fibula? Is it in
yes,
one stage, or I think slowly?
in this case, there are different ways of doing it. Occasionally, fibula is very near the tibia. It is malunited and very near the tibia. In that case, we can just transfer in one stage. How to do it? Don't damage the muscles in between. Take a proximal and distal incision, osteotomize proximally and distally, and then just shift. You'll be able to just shift the fibula to the tibia. Now, hitching it inside the tibia becomes challenging because generally in a non-union scenario, significant fibrosis has formed. So more often than not, you need to take an incision on the tibial side. Go from the medial side of tibia and open the posterior medial corner of tibia. Open the posterior medial the soft tissues in the posterior medial corner of tibia, and then put in a small clamp proximally and distally and pull the fibula and hold it. Occasionally, you can just shift with an Elizaro fixator using a beaded guide wire. And lastly, I'll just illustrate a case in about 5 minutes time. Just give me a minute. Can you see my screen? Is my screen visible now?
Yes, sir.
Okay.
Yes.
So another way of using fibula for challenging cases. So this was a young gentleman who presented at 3 weeks with right tibia segmental fracture grade 3. He had a closed femur lateral condyle, which was first diagnosed at our institute, and he was advised amputation elsewhere. This is how he came in. Extremely foul-smelling discharge, and that's the X-ray. You can see there's a large segment here. This is how he was, debridement and suturing was done, and high counts and everything. So this is after giving wash. He had a infection with Enterobacter, which was resistant, and he was treated with metrogyl colistin. And you can see this is post debridement. Now again, you can see this bone, and that was a mistake on day 1. I should have excised this on day 1, but one just gets tempted. And while proximally, the duct test was positive. There was distinct soft tissue attachment posteriorly. The superficial part was exposed. So we decided to cover it after taking out the superficial part of the bone, make the bone bleeding, and then use a cover. So here you can see the plastic surgeon has rotated a flap from posteriorly and covered the proximal part. Now he has covered this proximal part. We have taken out, used osteotomes to take out layer by layer till we had bleeding, and then he used a cover here. So now you can see this is covered reasonably well. This is after I have excised the lower tibia. This is, we've stabilized the fibula. This is post skin grafting. Again, we are not there till destination because there's a large defect. Then we did a cross leg flap. Here you can see flap after excising this. We have a reasonably aligned bone. He started forming bone. I was just hoping that nature will help, but it didn't. So what do? We use a ring fixator with transport or an internal fixation. Now this was almost 1.5 years post injury and there was no infection. So I thought I'll go ahead with an internal fixation. And we did a MIPO, thinking that this will encourage healing and then we will be able to put grafts. Unfortunately, you can see, immediately got infected. Within no time, the bone got infected. So we are forced to remove the plate at just 2 weeks. This is post removal of plate. This is post negative therapy. Then again, the first step is obtaining cover. So we obtained cover. Again, we really don't know what to do. Something needs to be done. And this is where, Dr. Aisha, this is where we shifted the fibula. You can see the distal fibula. We osteotomize here and then put the fibula into this lower end tibia. Here, there was a significant gap, while here there was hardly any gap. So here, we just pushed this, put a graft and supported, fixed it with screws. So this is, you can see, that's a bone graft. We have shifted the fibula without actually doing superiosteal dissection. Just proximally and distally we have osteotomized. And this is where we are after healing. You can see the fibula is healed very well here. Fibula is healed very well here. Absolutely consolidated. And that's the knee range and appearance. So there are various ways of shifting fibula, but that helps tremendously in reconstruction of these challenging cases. Is Dr. Wagh there? He has a case, right? Yeah, on transporting fibula, is weight bearing required to stimulate osteogenesis? Absolutely, absolutely. And that is why Elizaro is better, because you can allow weight bearing. Within no time, they go from partial to full weight bearing. The bone formation really improves with weight bearing.
Okay, sir.
I think Dr. Tanay had shared the case.
Yes, sir.
Tanay had shared. Okay. That sickle cell anemia?
Yes, sir. Yes,
Yeah.
sir.
So you had shared. Okay. Sorry.
Yes,
Yeah. So what are your plans?
Sir, first of all, I'm not even sure whether that sunburst appearance on the lower end fibula, whether it's osteomyelitis or whether it is because of the sickle cell because up until now he's a very socioeconomically very poor person. So up until now he was not even diagnosed with sickle cell. So I really don't know whether the bone curettage and antibiotic bone cement is needed or not.
So the first step is managing sickle cell. Generally, it is not by transfusions alone. Generally, they do give hydroxyurea and so many things.
Yes,
So
sir.
first and foremost is stabilizing him well,
Yes,
which
sir.
would take good 2-3 months.
Okay. Yes, sir.
Once that happens, keep, of course, doing a good dressing. Once that happens,
Yes, sir.
you can do a very, very aggressive excision of the wound. In one go from all sides and excise everything, whatever it is.
Okay,
Excise
sir.
everything. Certainly, MRI would be needed to differentiate from whether it is an osteomyelitis fibula or not. But in my opinion, it is just a chronic stress reaction. Very,
Okay.
very likely that your ulcer will be only involving up to deep fascia and not go beyond that. Very
Yes.
likely.
Yes,
In
sir.
that case, you can just excise, whack at least once.
Yes,
You
sir.
can even use, if the patient is really socio-economically challenged, Indian wax are very good. You can certainly use those in-house wax or in-house negative pressure system. But I don't remember who had shared the presentation, Aditya.
Correct. Connect it with the suction tube within the hospital.
Actually, I have a KCI wax, sir, and I
Okay.
reuse those canisters. So it becomes really economical. I save 1 or 2 canisters for them.
Right. So you can use them, but
Yes, sir.
very likely that it will not be deep. Though get an MR done.
Yes, sir.
And as I said, most important thing is addressing sickle cell.
Yes, sir.
It's all second.
Yes, sir. Another challenge is, sir, he has a 6-year-old neck femur
Huh.
on the same
Huh.
side.
Wonderful. Wonderful. So he's been walking with that.
Yes, sir. He has shortening of about 5 centimeters and he's walking on it.
So why bother? With sickle cell, things can be very challenging.
Yes.
They can be very, very challenging. They can get infected and there could be a lot of problems.
Yes.
So avoid, if he is walking on that.
Yes,
What
sir.
is your opinion, Dr. Thakur, sir, and Aditya?
I'll just share the
Sure.
neck femur X-ray, sir,
Okay.
on the WhatsApp.
Thakur sir is unmuted.
The X-ray might be very interesting, but so what is more practical? That guy has not been complaining of limb for last 6 months, and had he been
6
a
years, sir.
normal person,
6
we could have
years.
done something for him. But with
years.
sickle, lesser is better. So I would leave him alone till he actually comes back, says, "Do something for me." Then things could be taken up. Otherwise, just treat his present condition and say thank you very much.
Give him 2 days and say thank you very much. Don't get into reconstructive surgery in sickle cell unless it is absolutely warranted.
Yeah.
Yes, sir. Actually, he's been refused by the other surgeons
Correct.
nearby.
Don't take it up for
Yes,
fever.
yes, sir.
This
Yes, sir.
wound you may,
Yes, sir.
if it is causing trouble.
Yes, sir.
Otherwise, just avoid.
He primarily came for the wound itself, sir.
Bas. Don't get tempted with that neck femur.
Yes, sir. Yes, sir. I've shared the X-ray, sir. If you can have a look on that.
Yeah.
Hasn't he already united there? The shortening. I mean, a lateral view on a CT would be ideal, but the shaft is probably fused with the head.
Yeah, just don't touch him.
Yes, sir.
Just don't touch him. Okay, we are coming to an end. May I request Dr. Thakur to summarize today's.
Sure. Today was an unusual lecture that we were discussing infection in the limbs, but not discussing anything about bone, which is unusual for orthopedic surgeons because for us, bone comes first. But what we discussed was very interesting and very, very informative. Starting with necrotizing fasciitis, what we see on presentation is just the tip of the iceberg. and one should be as wary of an iceberg as the captain of Titanic. Whenever you see a patient with infection, which you are not sure whether the bone is involved or but the patient is not looking very good, is very toxic sort of thing, the antennas must be raised and thorough investigation and detailed planning should be done um, to control his infection and get rid of that infection as soon as possible. Thereafter, we discuss this infecting organism classification, which is good for understanding and knowledge, but practically it wouldn't matter which kind of an infection is he suffering from, except for giving antibiotics for longer term. We then discuss the usual risk factors like high blood count or increased pulse rate, uncomfortable patient, etc., which are usual signs of infection when patients have serious infection down there. What was more emphatic was to know that the infection is at the deeper layer and one needs to address that area and then go on working on in that level and not just be happy with doing things little superficial to that. We considered the clinical infection. What was most impressive is that the pain is disproportional to the inflicted area, and that should raise an alarm. The pain is disproportional. Then patches of skin necrosis should also be raising antennas, and we should be very careful about that. Debridement and antibiotics is, of course, the bread and butter of treatment. And what is important to know that having done it once, it may have to be repeated when we are dealing with necrotizing fasciitis. It is difficult to be very extensive in the first attempt. One is tends to save or leave behind few things, but with more experience or with more backup from lectures that like what we have been doing, it should be possible to go to a higher extent and do the best of the job on the first attempt so that the patient recovers very quickly. What is unsettling is that mortality in necrotizing fasciitis is as high as 20%. Uh, Out of 15, 3 people died in the cases presentation, which is a very high thing.
Yes.
So for the audience, it is essential to know that whenever you suspect that the deeper layer of the limb is affected at the facial level, you should be all out, very aggressive, and take as much help from the other people like plastic surgeons and the infection disease specialists, and not let your guard down till the patient is actually comfortable and walking. Next came the toast of today's presentation, a presentation imaging. What was most impressive was first the anatomical discussion to delineate where do we stop calling it cellulitis, where do we call it deeper muscle, deeper infection, and where do we go for the muscle thing. And that was really the landmark in that presentation, and that make the points very, very clear where to say cellulitis, where to say necrotizing fasciitis or fasciitis, or where to say it is myositis or polymyositis. The pictures of MRI and CT were very impressive. However, even during the discussion, I raised that if you are in a big institution, at the drop of hat, you can ask for all these investigations. But in a smaller setup, which I suspect a lot of participants are working at, it is not so easy. And then we ultimately discuss that it is the clinical judgment or clinical awareness that will save the day. But whenever possible, of course, MRI and CT would help you. Even to some extent, sonography would also help you. But nothing like suspicion, clinical acumen and that would work and good, will have good this thing. Necrotizing cellulitis is a deeper level. The abscesses could be at different level also. So it could be superficial, it could be deep, and it's difficult to say where abscess will form. But if the infection rate is dropping down, and we can expect abscess, once you localize it, it should be drained. That should be fine. Importance of serial photography, delineating the margins and investigation was very well brought out, and that should become a clinical habit, that you should take serial photographs right from the first day and store them so that you can note the progress. It also helps in telling the relatives that if the things are not working properly, you can say it was like this, it is gone like that, or the other way around. If it is improving or depressing, showing pictures really goes well with relatives, and one should take this new method or recording thing with your camera, with the phone camera. This has become extremely easy, and one should use them very, very often. Polymyositis or multiple infection, multiple abscess in the muscles was revealing, and as it was brought out, these are newer stuffs, these are rarer stuffs, but when they happen, they could be life-threatening, and more aggressive treatment is required. That is what we surmise. Aggressive debridement of tendo Achilles infection was a very instructive thing. We are always worried about excising in that area and thinking all the time that how will we replace the power of tendo Achilles. But time and again we saw that once the infection is gone, the skin is covered, the fibrosis becomes so good that nothing else needs to be required. So next time we get a infected tendo Achilles, we would be more confident in treating this the way it has been discussed there. The rest of the thing was real fantasy, nature's magic, etc. One needs to have a lucky patient and a lucky surgeon. And these are all unreproducible results. So we have to just take them as amusement or as something to remember, but not to aim for it when you are actually treating it. If it happens, wonderful, you are lucky, but you can't say, I will leave it alone and things will go. Remember, Mother Nature is not very kind. It's very rarely it's kind. In fact, one fellow says, Mother Nature is a bitch. She will always debacle everything else. So overall, the infections in the limb, but not in the bone, was very instructive and would make all of us more aware of these possibilities. It will also tell us how that we should be more aggressive at all stages and control the infection as fast as possible. Thank you for the two very good presentations this evening.
Thank you very much, sir.
Thank you.
Again, I will stress what Dr. Thakur has stressed. These magic of nature were extreme cases. All we are trying to stress is do aggressive debridement, appropriate stabilization, and of course, all other things. Then Mother Nature will help you. Independently, it will not help you. These are, as I said, only extreme cases.
I would say don't depend on Mother Nature. Do your thing properly and hope that she will help you.
No, agreed. I totally agree with you. All I'm trying to say, after aggressive debridement and appropriate stabilization, things will be very useful.
Yeah, of course. Of course. That's the way to go.
Yes. Yes, sir. Anything else? Anybody has any inputs, questions? Okay, next time we will be discussing soft tissue covers, something which even an orthopedic surgeon, many of them, orthopedic surgeon would be able to do. We will not discuss as Dr. Thakur said, fantasies like live fibula graft and microvascular transfer, will restrict ourselves to something which an orthopedic surgeon or average plastic surgeon can do. If there are no more questions, Dr. Aditya?
No, there are no questions.
Okay. So we'll call it a day. See you next Saturday, friends. Bye-bye.
Thank you, sir.
Bye.